Good afternoon, everyone, and welcome to our echo session today, listening to long COVID. It's brought to you by Health Confianza, a collaboration between the UT Health San Antonio and the San Antonio Metropolitan Health District. Please note that we are recording this session so we can share it later, but your names do not appear in the recording, nor does anything listed in the chat. Thank you again for joining our session and make this time one of your priorities. I hope you and your family doing well. My name is Raquel Romero. I'm a physician by training, and I'm going to be the facilitator for the echo session today. Before we get started, I have some notes from our echo IT. Please stay muted unless you are speaking. If you have some issues, some problems with your connection with the audio or video, please send a message using the chat box to the echo IT. These sessions have a closed captioning option, so you can navigate in the Zoom screen in the window, and you can see that in the bottom of that, and you can select the menu, and you have that option as well. To help us with our attendance records, I would like to ask you if you please add your name, your title, and your affiliation and email address in the chat box. This is for our attendance records. We invite you and encourage you to participate in our session today by adding your comments, your perspectives, and your questions in the chat box. We are excited to announce that this series provides a free continuing education credit for physicians, physician assistants, nurses, pharmacists, technicians, and social workers, and also provide participation certificates for community health workers. Towards the end of the session, you will receive the information in the chat, and we are going to post that information towards the end of the session. Please complete the survey, the evaluation, and your certificate is automatically generated. You can also receive an email where you can access this certificate and reload the certificate. Please remember that this information is open to Tuesday, 5 p.m. Central Time. For those that are new to the ECHO sessions, ECHO stands for Extension for Community Healthcare Outcomes. This is a model of lifelong learning and telementorship that connects healthcare providers and healthcare workers to create a community of practice and learning. It's a very special space where we can share challenges, resources, and strategies to better support our community. Please visit our website if you to learn more about the ECHO sessions. This series, Listening to Long COVID, explore the effects of long COVID and share management strategies, including complementary approaches to delivery of care. At each session, we want to have educational presentation or panel, and then after that, we want to watch a video testimony from someone whose life has been impacted by long COVID. Then we are going to participate in our conversation, and I invite you to participate in our discussion. If it's possible, you can join us by video, particularly in that part. I would like to go ahead and do the introductions for our Confianza team, and I would like to start with Dr. Rolin, the didactic presenter.
Hello, I'm sorry, I missed the last part of what you said. It cut out.
We're doing the introductions, and if you please introduce yourself and tell us a little bit about yourself.
Oh, yes. Hello, everyone. I'm glad to be presenting today. My name is Dr. Summer Rolin. I'm a clinical neuropsychologist with UT Health San Antonio. I'm in the Department of Rehabilitation Medicine. And in our department, we do have a long COVID rehab clinic, multidisciplinary, working with different specialties to help patients with long COVID in their journey to recovery. We also have an inpatient facility as well, where we have had hospitalized patients that have been treated on the inpatient side, and then we like to follow them on the outpatient as well. So I'm glad to be here, and I'm looking forward to hearing everyone's opinions on this important topic.
Thank you very much for your time in presenting today's didactics. I would like to continue with Dr. Bergen.
Hi, everyone. I'm Dr. Ruth Berggren. I'm a professor of medicine and an infectious disease specialist at UT Health. I am the director of the Center for Medical Humanities and Ethics and a member of the Health Confianza team.
Thank you very much, Dr. Bergen. We have a Dr. Barnes.
Hi, I'm Niall Barnes. I'm a pharmacist at the University of the Incarnate Word School of Pharmacy and part of the hub team for this series on long COVID. Glad you're all here.
Thank you very much. Guadalupe Cornejo, think I saw you. Mhm.
Hi, yes, everyone. This is Guadalupe Cornejo. Thank you for joining us today. I bring my insight as a community health worker, instructor, and social worker. Good to see you all here. Thank you.
Thank you. Joaquin Abrego, Marco?
Peace, y'all. This is Joaquin. I am a community health worker with Health Confianza and a social justice activist. Thank you, guys.
Thank you. Thank you very much also for the whole Confianza team, for the ECHO team, and thank you all for being part of our presentation today. Well, with no more from my end, I want to just to mention that in all teach online environment, I invite you and encourage you to participate in our session today by adding your comments in the chat. So I would like to continue with didactics. Dr. Rolin, on your time, this is your space. Dr. Rolin is going to be presenting. Thank you very much.
Let me know when you're able to see my screen.
They look good, but we're seeing your presenter mode. So if you go up to display settings, Dr. Rolin, over to the left at the top, display settings, and then do swap screen underneath that. Does it give you the first option, swaps?
It does not, but we can do it this way.
There we go. Looks great.
Okay.
Perfect. Thank you.
Okay, so hello. I'm going to be presenting on the mental health impact of long COVID and implications for approaches to care and treatment. I have nothing to disclose for today, and the learning objectives, we're going to describe the impact of long COVID on mental health, talk about some vulnerable populations who may be disproportionately impacted by this condition, identify some strategies for supporting the mental well-being and health for patients whose lives have been impacted by long COVID. And we will talk about caregivers as well, I think after the video presentation, which is very important. We'll assess treatment options and recommendations and describe the impact briefly on healthcare workers and burnout in treating long COVID patients. So when we look at the literature for the expectation for the impact of long COVID on patients, especially as it relates to mental health treatments, really focusing on other post-infectious fatiguing illnesses such as chronic fatigue syndrome. These illnesses have a lot of research-based interventions that have been adapted to specifically address those populations who have limited access to being able to engage in some of our traditional psychotherapies like cognitive behavioral therapy, which the cognitive demands, the energy demands of those kinds of therapies aren't appropriate for chronic fatigue syndrome patients. And we're finding that that's very similar with patients experiencing long COVID. And long COVID can also be lumped in with some of the other post-viral syndromes and as far as what we see with the mental health effects. So being that we haven't had time to study some of the interventions that have been efficacious for long COVID, going to the literature for what works for other autoimmune disorders and things like POTS and mast cell activation has really been the go-to for psychiatric and psychological providers. So when we think about the risk factors for patients who may experience long COVID, we can lump them into two sort of categories, one being a health category and one being an illness severity category. So patients will be more likely to have long COVID if they do have comorbid conditions, such as behaviorally based medical chronic conditions like hypertension, high blood pressure, but also immunosuppression, diabetes, other kinds of poor health conditions. Psychiatric conditions are also an important factor in predicting who might have a mental health complication from long COVID, especially post-traumatic stress disorder. In those patients, we're seeing that there's a twice-fold trauma response to having experienced long COVID or going through long COVID as a chronic condition. We're also seeing an onset of symptoms of new disorders such as anxiety and depression. Now we know these things are common in persons with stroke or immunosuppressive conditions as a complicating factor, and we're also seeing similar complications in long COVID. As far as illness severity, some of the metrics that we try to track are the initial acute symptoms. Loss of smell, particularly, is associated with a complicated course of recovery from COVID. Also, the length of acute symptoms and onset of acute symptoms is also an important factor to consider in screening or identifying patients who may be at risk for the disorder. Those who had to have prolonged hospitalizations or ICU admissions are also likely to have more complications after COVID infection, but also likely to have trauma responses, especially those who were placed on ventilation. However, I did asterisk this with the caveat that most patients who present with long COVID to rehab clinics were never hospitalized. Some of them may not even have had a positive test because they had an illness during a time when testing wasn't available. The other complicating factor to consider is some of our patients aren't even sure how many COVID infections they've had. They may have been ill before testing was available and likely had COVID and then developed a different strain of COVID and then had a positive test. So we have to look at those factors when we consider who might be at risk for long COVID, and that we can't just traditionally look at metrics on paper, but have to consider the course and the significance of the illness. When we think about who might be vulnerable to long COVID, the research really supports a high odds for females, 1.5 times greater relative risk for females than males in developing long COVID. Age is also an important factor. Patients have an increase in their likelihood to develop long COVID up to age 70, and then a sharp decrease. And why we think that might be is patients that are elderly, the geriatric patients, were more likely to not have developed COVID because they were social distancing or isolating to their homes. So in that population, we can see more of the behavioral health effects of depression and anxiety that the high level of isolation and not being able to see grandchildren, children, church groups might have impacted the geriatric population. So even though they might not have long COVID, COVID had mental health implications for that population as well. A younger age is more predictive of loss of smell and taste in patients as well. Most patients do recover those senses, but especially for the loss of smell, there are smell therapies that are available to help them regain some of that smell identification ability. Other vulnerable populations for long COVID include Black, Asian, and minority ethnic individuals. They have an increased risk of infection, worse clinical outcomes, and more likely to be admitted, and a greater mortality rate than compared with their white counterparts. They also have poorer clinical outcomes. Some of the theories about why this might be are lack of access to identification of the illness, lack of access to testing in poorer communities, and also lack of access to resources. So many of these patients didn't have acute treatment. If they did have acute treatment of symptoms, there were not access to resources after they were released from the hospital. So although they might have had healthcare being hospitalized, once back in the community, once back sent home, they weren't given that same level of care and outpatient. They weren't getting follow-ups. They weren't getting, primary care visits, things that were really important in treating patients who have developed long COVID. So also a very important community health topic to consider. When we look at the symptoms that are most prevalent after 6 months, so this is a greater than 30% symptom report. You can see that at the top, I know this slide's a little blurry, but you can see at the top that fatigue is the highest symptom reported to being persistent after COVID infection. After that, post-exertional malaise. So when we're seeing patients with mast cell activation, with high histamine levels, with POTS, we're seeing a lot of that post-exertional malaise and brain fog occurring in those patients. There's other, dizziness, speech and language issues, brain fog, insomnia, memory issues, all of these symptoms we're seeing present after long COVID. And the best approach we will talk about is a multidisciplinary approach so that we're not missing symptoms that can be treated by things like nutrition, behavioral intervention, mental health intervention, or physical therapy, speech therapy, those kinds of therapies that can be helpful for specialty care. So the most common post-COVID psychological issues are acute stress disorders, so trauma reaction to have been infected, hospitalized, having all of this new onset of symptoms, not being able to engage in work or socialization as before. Also, anxiety and demoralization symptoms are also very high. We're seeing a lot of PTSD symptoms in these patients, so I commonly screen for PTSD. And not that I would always diagnose that disorder, but to gauge the level of trauma response a patient might have to experiencing long COVID. We're also seeing a high amount of depression and grief reaction. So we're looking at a lot of the bereavement models of treatment and treating patients who've experiencing long COVID and are really mourning the loss of what was their normal. When we think about psychiatric distress in this patient population, functional decline is common, and functional decline really impacts the quality and satisfaction of life for patients with long COVID. And thinking about how to address activities of daily living and functional ability is very important in rehabilitation of these patients, mostly because we have to know how the psychiatric distress is an overlay to the physical and medical symptoms that they're experiencing. That being a caveat that we don't want patients to feel marginalized, or like we're saying that a psychiatric reason might be, the underlying mechanism for all of their symptoms. We definitely don't want to say that this is all in someone's head. We definitely want to address the very real physical and medical symptoms that these patients are experiencing, but also addressing and bringing to light the mental health and psychiatric impact that these symptoms have had on patients. 35% of COVID survivors had one moderately elevated score across measures of psychiatric symptoms, including anxiety, depression, and trauma. And 1 in 4 patients required treatment in the ICU. I think I indicated this earlier, did report trauma-related distress for those experiences. And this was worse during the time when they were not allowed to have visitors. Family members weren't allowed to come to the hospital. They may have had family members already pass away from COVID and then themselves had to be admitted, and the trauma and grief response associated with that can be very complicated. Other mental health issues that we look at are, what are the economic losses? So just an example, like a vignette or a caveat, a patient that I've seen was a nurse who wasn't able to go back to her high-paying job in the ER. And the amount of financial impact that had on her family was very complicating to the psychiatric overlay of her symptoms and the trauma response that she experienced. And she was actually able to go back to her work in that capacity and was working as a school nurse, which was very different than the previous high-level, high-functioning job she was able to hold. And that can have a big impact on the mental health of a person and what their identity was. There's also increased responsibility towards children and family members, children who aren't able to go back to in-person learning due to themselves having immunosuppression or other sorts of disorders, cancer disorders, those sort of things. Takes a toll on the caregiving and that parents have towards their children and also their elderly family members who themselves might have long COVID as well and might be more debilitated. So there's a lot of different responsibilities that fall on these patients. Closures of daycare schools in the workplace were really devastating for people and for those with long COVID, adjusting to going back to those environments, but also not having the same resources and adaptive and compensatory strategies that once worked for them, given their symptom burden that they might be currently experiencing, are important to address clinically as well. and the social, just lack of social support. People kind of want to be done with COVID, and these patients are having to bring it up because they do need continued treatment for these symptoms related to having this infection. And so they can really experience a lack of social support from their family members who might just be like, okay, just get back to normal, you know. And it's for them, it's not that simple. It's not a light switch you can just switch on and off. Also the sense of loneliness and having going through this this disease process and this recovery process and living with the chronic symptoms of long COVID can create this impact of feeling very alone. You know, luckily there's many support groups now available. The Body Politic is one that is very good. It's a good resource. Their website has a lot of resources for things like not only support groups, but also, you know, applying for disability insurance coverage, other resources that might be available in the community. So for screening for symptoms, really the best policy is we use patient-reported checklists. So we use a post-traumatic stress disorder checklist and mood screeners for depression and anxiety. And we really encourage the primary care physicians to incorporate these into their clinics so that they could screen for these issues patients might be experiencing and then direct them to the appropriate specialty care. We're using cognitive remediation therapy through speech therapists. So speech therapists don't just treat speech disorders. They can also be very helpful for things like brain fog and memory strategies. Physical therapy is very important for falls prevention and also addressing postural instability. And we probably refer every long COVID patient we have to physical therapy to address those, because most of them do have conditions like POTS, heart rate variability, oxygenation, or reduced lung capacity that we want to consider with physical therapy. And some of the pharmacological treatment examples, antihistamines we're seeing a lot of really good outcomes for those, but also beta blockers, clonidine for anxiety, those sorts of medication. Here's just sort of the screening measures we've been using. We use the GAD-7 for anxiety, the PHQ-9 for depression, and the PCLC for trauma response. And once again, not to diagnose PTSD per se, but just to gauge the level of trauma a patient has. Some of the cognitive treatment strategies that we're doing, I conduct neuropsychological evaluations with COVID patients experiencing brain fog, especially those who also had a co-occurring stroke or ischemic attack due to their COVID infection, where they're having a lot of neuropsychiatric deficits that need to be quantified so that we know where the areas of strength and weakness for return to work, return to functioning might be, and what therapies we can help. We're also helping build routines, organization, limit distractions, and pacing. Pacing is the biggest thing we can do physically to help patients get back to being active and increasing lung capacity. We use the energy envelope theory, meaning that there's only so much energy you have, and keeping your activity within that envelope so that you're not overstressing your physical ability at that time. Behavioral treatment strategies, these are ones that we recommend for every patient: reducing carbohydrate heavy meals, lowering the histamine in your diet. There's very specific tailored low histamine diets available. Minimizing heat exposure. In Texas, that might be very challenging, but minimizing that when possible, but also balancing out, ability to exercise, garden, do things that might require being in the heat, but maybe limiting the time or increasing the water intake during that time. Also making sure salt intake is under control. 5 to 10 grams is what we're recommending. And sleep hygiene. Sleep disruption is a very big factor for a lot of long COVID patients that's never addressed. And so that would be a really important one to focus on. Some of the other treatment strategies we've seen, we think about instilling coping strategies for management of depression and anxiety, but also some non-traditional yoga we found is very effective. Gentle yoga, gentle stretching, doing things like deep breathing, but with caution because of the lung capacity and breathing issues that can happen and the low O2 saturation in some patients. We want to really make sure that the patient's appropriate for a deep breathing intervention. Gratitude exercises we found are very helpful. Listing 3 things you're grateful for at the beginning of the day has actually been associated with improved mood over time. And that just brings in mindfulness and those other kinds of techniques to these patients. Trying to be mindful of the time. I think I'm almost there. So So just very briefly, physician burnout is very important to think about. There's a difference between burnout versus compassion fatigue. Burnout is more, systemic and hazardous in organizational environments that create, poor work environments for healthcare workers. But compassion fatigue is what we're seeing a lot in patients treating long COVID, because it's this exposure to prolonged traumatic events. And some of these physicians may have had COVID themselves and may be dealing with long COVID as well. And so making sure we're addressing compassion fatigue and making sure that that's not contributing to poorer patient care or poor self-care for the physician as well. Okay, so I think I'm right at 12:25. So I just want to put this up if anyone's experiencing any kind of mental health crisis. These are some great resources that we have for you to consider, especially if you're a physician and you're experiencing thoughts of suicide or very increased compassion fatigue or even burnout. This is the physician support line.
Thank you very much, Dr. Rolin. Is there any questions for Dr. Rolin from the Learning Network?
I have a question. Can everybody hear me?
Yes, please.
Okay, sorry, I was in the ER with my husband all night last night, but I'm a long COVID person for 2 years now, and I've been a cardiac nurse for 30 years and forced to retire as a nurse. But my problem is I have trouble finding a physician who gets long COVID, who wants to treat traditionally, like, oh, you're just depressed, or, well, no, I was a marathon runner or a 14er, climbed mountains. I can no longer go to the mailbox without being tired or whatever. So I'm having trouble. And I work with, my doctors, Dr. Gutierrez and Dr. Sanka, and they're very helpful, but I just don't know where to seek psychiatric help.
Yeah, thank you for sharing that with us. You're definitely not alone in that frustration. We do have a dearth of providers that are specializing in this. And so I think looking for a mental health provider or psychiatric provider who has experience with things like chronic fatigue syndrome or other similar post-viral fatiguing illnesses is a really good strategy to find a provider that understands the complications of your condition and of others who are suffering from long COVID. Also, the website I mentioned, The Body Politic, does have a lot of resources. I encourage you to see if there's some providers identified on that website. I've had patients have success through that website for multiple things, resources and things.
Okay, good. Yeah, that's the thing. I had neuropsych tests in the beginning when I was severely cognitive impaired, and 2 years later I feel like I'm more clear-headed, but the cognitive test showed not. It actually worsened, and I don't have the critical thinking. I don't have the same things. And you were talking about ER nurse, and that's me. I'm a cardiac nurse, electrophysiology nurse, and I'm having trouble finding somebody without explaining an 18-page dissertation about long COVID, because I belong to long COVID committees, and I'm just having a hard time finding a physician who gets it, like, oh, you have a right to have PTSD or social anxiety. You don't want to leave your house because you couldn't complete sentences in the past. So that's it. It's a little frustrating because you have to explain everything.
Thank you so much for sharing. And like Dr. Rolin says, you are not alone. There is a lot of to talk, and this is why we have those sessions. And thank you for sharing. I see your hand up, Dr. Bergen.
Hi. I thank you, Jennifer, for your comments and your frustration at not finding that all physicians understand what long COVID is or are receptive to helping a patient with that is the very reason that we are conducting this Listening to Long COVID series. So we're right there with you, and we're trying to make a difference. I've reminded people at the last session, and I'll say it again in this one, there's actually an ICD-10 code for long COVID. And if a provider is acting like they don't think that long COVID exists, one could start by pointing that out.
Okay.
But getting back to your question about mental health support, which we just lack mental health care professionals in our community and across.
Absolutely.
I have a question for you, Jennifer. Have you tried to initiate any kind of peer group support group? And what has been your experience with that?
Well, so I started a long COVID Facebook page for, anybody else suffering long COVID. I also did a long 17-month long COVID research committee with Dr. Gutierrez. And everyone touches on mental health. It's just getting to the right person, because I do follow, I have a Facebook page that is devoted to long COVID. I've tried those things because they're obviously behind the scenes. I don't have to look at people. I can just post stuff and tell them about stuff. And the best I've gotten out of this whole, it was a huge, from Washington, and I was also on CNBC for being denied disability because they don't see that. But the hardest part is finding someone who's like, you're not just depressed, you don't just have anxiety, they want to clump it all together. And I'm like, but I was a healthy individual, very, very healthy. And so it's been hard. That's a big struggle. And I'm still waiting now for 2 months to see a new psychiatrist, because mine was just an outdoorsy guy. It's just, it's hard for people to find somebody.
Yeah, it is. Dr. Bergen, I'm sorry, you want to say something?
Oh, no, I was just thanking Jennifer for being kind enough to share her experience with us. Thank you, Jennifer.
Yeah, thank you for your
Thank
kindness,
you.
and
Thank you for responding.
And that's why we're here, and that's the essence of those sessions. Thank you so much, and we're gonna hear more. We hear last week. This is real. This is there is a lot of symptoms, like Dr. Rolin mentioned. There is before next we're gonna have a video, but I see here that asking for the information on where to get smell therapy. Dr. Rolin, do you have some information on that? Information on where to get smell therapy? Maybe we can go back to that. And there is another comment that my personal experience with long COVID is so closely related to everything you have mentioned, low carb and salt. Diet has been incredibly helpful, as exercise and yoga, as you mentioned in the presentation. The anti-inflammatory homeopathic also is been helping, like cherry juices, turmeric. Thank you for validating those experiences. Those is a comment in the chat that I wanted to read. And as a part of our sessions, we prepare this agenda where next we wanna watch a video. In those series, we're gonna be watching a video testimonial from someone has been affected by long COVID. And our next video is from a caregiver. There's someone who has been impacted by long COVID, is a family member. So the caregiver is presenting this story for us. Thank you.
There's 5 of us in the family, so all of us ended up with COVID, but he ended up with more of the symptoms. He ended up getting worse instead of better. It was like a week and a half, and then he ended up in the hospital. So in the hospital, the doctor told us that it was pneumonia. He had developed pneumonia. After the pulmonologist said, okay, you're able to go home, he came home, but he was very weak. He had lost muscle in his body, so he was very weak. So I had to take care of him, you know, help him shower, help him go to the restroom, you know. It was mostly tending to him, to his needs. But because of my girls, you know, we were able to work together, you know, help each other. So our focus was trying to get him healthy again. I guess with our relationship, it brought us closer. Just him being very thankful that I was there to help him. I'm a housewife, so I was able to do that. Him not being able to go back to work, us being, you know, me being worried about, is he going to be able to go back to work? Is he going to be able to go back to doing the normal, regular things? And then for some reason, because of the steroids, we found out that his sugar had gone up. They didn't tell us that because of the steroids in the hospital, they were doing insulin, but when they send him home, they send him home with steroids, but no insulin. And we didn't know that you know, that the same steroids were causing his sugar to go up. We just kept the faith, you know, that he was going to get better. And little by little, seeing him, you know, getting his strength back. There's going to be good days and there's going to be bad days, and just to try to be there for that person to as best as you can, you know, yeah, to take care of them. The only thing that maybe that I can think of is giving the patient more time to be able to ask questions and to be able to share as many details as the symptoms that they're feeling. And then taking the time, I guess, to just listen to the patient and trying to figure out the best way to maybe treat the patient. The doctor, not the pulmonary doctor, but the regular doctor that saw him at the hospital, my husband went in on Friday, I believe. And by Sunday, she wanted to send him home, and even though he didn't feel well. So what he did, he told them at the hospital, I don't feel well enough to go home, you know. So because of the pulmonary doctor, he was the one that told my husband, you will tell me when you'll go home, when you feel well enough to go home. So that was the only thing that maybe concerned me, because you always think like, okay, so if he would have gone home Sunday, would he have gone worse instead of getting better, because they were treating him at the hospital. Keeping informed of, say, boosters or like the flu shot, and then just trying to stay healthy, so that hopefully our immune system is strong, so that in case, I know COVID isn't going to go away, that's what they've been saying, so trying to just stay healthy so that, and keeping up with our, say, the flu shot, the boosters, so hopefully we won't end up getting COVID.
see in this, it's a very interesting and very sad story. We feel a lot of empathy for everything that she was mentioning, and she's a caregiver. So we'd like to open up this conversation in our network. If you have any, what do you hear and what do you observe in this story? Dr. Rolin?
Oh yeah, I was just going to say, I heard a lot of the grief response that I was talking about during my presentation. A lot of grief and loss, and the way that her life has been turned upside down, and the different role that she's had to take now as a caretaker, and also being impacted by her own illness, but also the illness of her husband, and seeing what losses he's had. I would really, suggest that psychotherapy focus on bereavement and grief for her adjusting to this chronic condition.
Exactly. Yeah, and yeah, so she was suffering as well, and now, but also she may. You mentioned in your presentation the multidisciplinary approaches. Would you please elaborate a little bit more on that and give us a little bit more explanation about what that means and what it represents?
And for multidisciplinary approaches to care, when we think about incorporating specialties like physical therapy, speech therapy, increasing exercise, lung capacity, and pacing, for her husband, because of his limitations, that she might be an appropriate candidate for in-home rehabilitation. So we have Rehab Without Walls, which can actually go to people's homes and reduce the burden on the caregiver for what I call appointment fatigue, which meaning, having to take their loved one to all of these various appointments is time consuming, and with the travel, the burden financially, and also, the just navigating the healthcare system. And so I think, using some of these at-home resources, I would really encourage. Rehab Without Walls here is doing a good job with these patients.
Yeah, thank you very much. We also, this story is from a caregiver, and some of the things that she was mentioning is keeping informed, be healthy, get the vaccines. Dr. Bergen, I wonder if you can tell us a little bit more on that using the lens of the health literacy.
Thank you, Raquel. I think that we all heard the need for a team. All right, there's a team approach. That's what we're talking about when we use the term interdisciplinary or interprofessional care. I want to highlight the importance of the caregiver as a critical team member. And one thing that I love when people come to see me in my outpatient clinic is when they bring an accompanying person with them. The accompanying person, should be someone that they trust, that it's okay for that person to hear about the confidential health information. But besides just being there to be a supportive friend, that accompanying person can be a critical member of the team. The person with long COVID may be experiencing brain fog. They may be having memory problems, or they may be perfectly fine with their memory, but they're feeling upset, traumatized, so that much of what they hear kind of goes in one ear and out the other, not because they're defective, but because of the circumstances in which they find themselves. So what does the team member need to do? Help them keep track of what's going on. So for starters, just note-taking during the visit, that can be super helpful. But there's also a strategy and a little memory aid that I like to use, and that's called Ask Me 3. So try not to remember 5,000 things, but try to remember 3 things. And when the caregiver accompanies the patient to the healthcare provider, they should be thinking about what is the main problem, what is the most important. There may be 5 or 6 things and they may be all valid, but like what's at the top of the list? What's the life and death thing? Is it the insulin, for example? That all the other things are important, but if you don't have insulin and you're diabetic, that is really pretty critical. So the first in Ask Me 3 is, what is my main problem? The second one is, what am I supposed to do about it? Is there a prescription for the insulin? Do I have an appointment to go and learn how to use insulin from a diabetic teaching nurse, as an example? What is my main problem? What do you want me to do about it? And then the last one is, why is it important? Because sometimes people go to a specialist and they hear about all these fancy things they're supposed to go do, but if they don't really relate those actions, behaviors, pill taking to solution of the most important problem, it doesn't stick. So the Ask Me 3 mnemonic is helpful to think about before you go in, during, and then afterwards. And if you realize you're walking out the door and you don't know the answer to why it was important, then maybe the caregiver can remember Ask Me 3 and say, now, why was it important that we go and get that prescription filled for whatever it was? Thanks.
Thank you very much, Dr. Bergen. Yeah, I have heard about the Ask Me 3. So it is always good to have a notebook when we go to see the doctor, because we may forget something that is going to be important, and as a caregiver became very, very important as well. If you have a comment or question, I invite you and encourage you to add those in your chat box. That will be if you feel like it. Is there another? I wonder if how does this story help, or maybe not, to engage with other individuals like this story that we hear.
I don't deliver care to patients, so I might not be the right person to answer this, Raquel, but one thing I was struck by is what she mentioned, taking that extra time and listening to what people are going, like listening to experiences, and because people don't rattle off necessarily all the most what might be medically pertinent symptoms right away. So creating space for that, which I realize is a really difficult thing to do in an already busy appointment window. But that certainly does strike me as something valuable Sandra offered.
Yeah, always. It is so important just to take the time and listen carefully. Those are some of the principles for celibacy. I will ask also if Eddie Sanchez, if you can elaborate more a little bit in your comment in the chat.
Maybe he didn't hear. Eddie Sanchez, are you able to unmute? You're muted.
You're muted.
Yeah. Okay, here we go. Sorry.
Perfect.
Yes, I dealt when you Dr. Rolin, when you showed the chart, I was all over that chart with the things that I dealt with, and I think that part of my deal was, as a chaplain and former pastor, I was trying to deal with other people's pain and thus had a focus other than my own, and that helped. A close friend of mine lost his only sister, his mom, his only brother, and his mother-in-law in a 2.5-month period, all due to COVID. And so I think that kind of shook me up a little bit, and I was able to focus, how you say that you focus on other people that are dealing with more than you are. It just kind of made my load look lighter. But it's the thing that helped me, I think, the most was actually finding a neurosurgeon that was willing to hear something other than himself tell me, let's schedule surgery, and allowed me to have the option to meet with his physical therapist. And she was a tiny lady. She's probably not even 5 feet tall, but she stayed after me, and that helped me get mobile. And that was a big hope booster, because it allowed me to move on a little bit at a time, but still move on. I had pretty well lost all hope listening to the young lady that was a nurse. I was there. I was working with Homeland Security as a chaplain, and would work up to 90 some odd hours a week, and it was not a problem. And suddenly you can't even stand. Vertigo was just, I couldn't walk without a cane, or even sometimes stand in the middle of the room without falling over. So but I'm still struggling with it. Now I'm working as a chaplain again, and it's a large corporation, and probably 15 to 20% of the folks there have dealt with COVID in different intervals and in different situations. But so we may have to start something there with them to try to get them. And then of course diabetes is really big among that group. And so this past week we had one gentleman that lost part of a toe due to diabetes, and he was already dealing with other issues. So it's just a big part of our society that has been silently suffering because we don't know what to do, where to go, or just feel like maybe it's just all in my head. So that's my own family just couldn't believe that I had gone from one end to the other. So that's where I'm at. And but like I said, well, I'm moving forward because I do still have contact with my physical therapist, and so that's helped a lot.
Thank you very much, Eddie. You mentioned about the physical therapy. You sounded cutting a little bit.
So much to be done.
Dr. Rolin, it was
Pardon?
in your presentation. Thank you very much. It was cutting a little bit the audio, and you mentioned about the physical therapy because you mentioned some situations with balance. Dr. Rolin, you mentioned that in your presentation.
Yes, thank you for sharing your experience. Balance and falls prevention is a very, very important to address, symptom to address, especially because some of the balance issues have led people having a broken hip or other things that then can further exacerbate the medical conditions and symptoms, especially people who have stairs in their home or other kinds of limitations just by where they live. People can't just move homes a lot of the time. And so having a physical therapist come to the home also can be really important to sort of help see what you can adjust in your home in order to prevent those fall prevention, especially if you're using a cane or other assistive device. So I would suggest that that's also an area for treatment that can be helpful for home health. Yeah, postural instability is definitely one of the biggest symptoms that we see with these patients. And also what struck me about what you said was the feeling that, is it all in my head? And you're not alone in that. Many long COVID patients feel like they've been marginalized and dismissed because of the psychiatric symptoms that might be experiencing or because providers just aren't educated on long COVID. So, I think support groups actually can be really helpful. And I think the body politic link was posted in the chat. So I encourage everyone to follow that link. I'm also part of an ECHO through the University of New Mexico for long COVID. And a lot of the survivors that participate in that ECHO have said that they've found very, very beneficial support groups online that don't require them to travel anywhere, that they can do virtually, that they can do via Zoom or with their video off altogether if they're just having a bad day with fatigue. So that would be another support area I would suggest.
Yeah, I'm also advocate for the support groups. Is always very, very, very helpful because it's the help that we receive from each other that is very valuable, right? And validate the symptoms that you mentioned. Is there another experience from working in support groups, Dr. Rolin, or in peer groups that you can share with us?
Yes, so I've had patients who've been very active in online support groups. I think Jennifer mentioned Facebook groups, and they've actually been very imperative in legislation and other kinds of state and national lawmaking in order to address access to resources for patients with long COVID and including disability and insurance coverage for this disorder. As Dr. Bergen had mentioned, there is an ICD code. It is billable with insurance, and I think a lot of physicians just haven't been educated on that. So I'm glad that was brought up. But I think support groups have really been integral in also making change at a bigger level.
Thank you very much, Dr. Bergen. I think you also have a comment in the chat. Maybe you can elaborate a little bit more.
I'm just listening here, like we intend to be, listening to long COVID. And from what I'm hearing, it really does look like we need to compile resources locally. Mia, thank you so much for putting a lot of links in the chat to national societies, which also can then help us link and find local groups. However, I'm thinking perhaps we can band together and on a Bexar County level, identify a list of providers who would say, yes, I know what long COVID is. And yes, my particular profession, whether I'm a cardiologist, a psychiatrist, a physical therapist, I'm interested and willing to take patients who are suffering from long COVID. And that might take a little bit of the Easter egg hunt frustration away from people who are already having a lot to deal with. I think there's a real need for it, but we're going to have to take collective action around that one.
Yeah, that's true. I think we've been here last time and now last session and now here today, that resources and knowing where to go and that we are not alone. I know Dr. Barnes, you joined us today. Thank you so much for joining our session. I wonder if you have any experience that you would like to share with us in terms of the long COVID.
I've never had long COVID. I had COVID a couple of short visits, so I'm very fortunate in that respect. But Dr. Bergeron made a comment about, we need to be listening. And the thing that I'm hearing from everyone here is the patients need to be speaking for us to listen. And so I think one of our most important duties is to encourage patients to speak up. We had a couple folks here today that were willing to do that, but not everyone is. And so encourage it, positive feedback when we do get people speaking up so that we can collect this information and learn from our patients what works and what doesn't. We might get somebody says, I'm willing to talk about people with this, and yet we don't get good information from the patients who go see that person. So maybe that's not the direction we need to send them. And we get great information about, someone wants to go see Dr. Rolin, great, let's funnel as many people as we can there that can be managed. So that would be my take from today. Encourage speaking so that the rest of us can listen.
Thank you very much. We have a couple of more minutes, but is something that you would like to add, Dr. Bergen, in terms of health literacy? We mentioned a couple of principles, but you would like to extend a little bit more?
Well, since there's a long pause, I mentioned Ask Me 3, which is something that everybody can get involved in, right? The caregivers can remember Ask Me 3, think about it before, during, and after. The patients can think about it. So it helps them prepare and focus their visit to get the most out of it. But then on the provider end, and I know we have some various different kinds of health professional providers on the call today, remembering the teach back method, which is to, after you've explained something, to inquire in a very deferential way whether you've been an effective communicator. Let me see if what I said made sense to you today, Andrea. Can you please tell me in your own words what it was that I wanted you to do with that insulin that I prescribed? I want to check myself to see if I communicated well, and that takes the burden off the patient of feeling like they have to perform. You don't want to give them performance anxiety, but shows them that you're evaluating whether you did a good job in communicating. So the teach back method can really help when people are juggling all kinds of things. People go to cardiologists and neurologists and psychiatrists and physical therapists, and everybody's got a set of instructions. It can get overwhelming. So those are the health literacy tools that can help the patient and the caregiver and the providers to be more effective.
Thank you very much. Thank you very much. And we are now at the end of our session, but I would like to just bring a couple of summary points that we talk about the risk factors. We also talk about who is vulnerable for this long COVID. It was mentioned about females and males. Also, we talk about the symptoms. Fatigue was one of the most frequent symptoms. We also talk about depression and anxiety for some patients that have a long COVID. And we talk about the caregiver and what is the ASB3, caregivers and patients. They can use that, and from the provider perspective, the CHMS method. So I would like to say in this time, thank you so much, Dr. Rolin, for this wonderful informative presentation. As always, Dr. Bergen and Dr. Barnes as a part of our team, and to you all, thank you very much for sharing your experience. And you all, thank you so much for joining our session today. Please join us next week, next Friday. It's going to be March the 10th. Dr. Peterson is integrative health approaches to long COVID management is going to be the didactic. So we're going to have this week. Until then, thank you very much, and you have a wonderful time.